the results of a multicenter, multi-institutional trial which evaluated the role of pomalidomide and low-dose dexamethasone in patients with relapsed and refractory myeloma. As you know, multiple myeloma is the second most common hematologic malignancy, and over the last decade, significant progress has been made for the majority of these patients. We expect today that the median survival of the average myeloma patients exceeds 7 to 8 years, whereas 10 years ago it was 2.5 years or no more than 3 years. However, more and more patients survive for extended period of time, and they become, at the end, resistant to what are the most effective commercially available agents today, such as bortezomib and lenalidomide. Dr. Kumar, a couple of years ago, reported that the outcome of these doubly refractory patients is very poor. The expected progression-free survival is no more than 5 months, and the expected overall survival of these patients is approximately 8 months. Thus, in order to improve the outcome of these patients, there is a need to develop novel agents, new drug combinations that may improve the outcome of these patients. So, based on extensive experience with pomalidomide dexamethasone in phase 2 trials, which have indicated that this combination may induce responses in 20 to 30% of patients with myeloma pretreated with lenalidomide and with bortezomib. A prospective randomized trial was designed in order to clearly define the role of pomalidomide and low-dose dexamethasone in this disease setting. Here is the design of the trial. Patients were randomized on a 2-to-1 basis to receive either pomalidomide at a dose of 4 milligrams daily, 3 weeks on, 1 week off, and low-dose dexamethasone continuously at a dose of 40 milligrams weekly or 20 milligrams weekly for patients older than 75 years of age. The control arm was high-dose dexamethasone because this is the treatment that we often use in order to palliate patients for whom we don't have any other treatment options. High-dose dexamethasone consists of an intensive dexamethasone approach, 4 days on, 4 days off continuously. Patients were to be treated until evidence of progressive disease. However, patients who were randomized to the high-dose dexamethasone arm at the time of progression were crossed over to pomalidomide in a companion trial. This is the flow of the patients. 455 patients were randomized, 302 to pomalidomide dexamethasone, and as you can see, one third of these patients continues on treatment. The remaining patients have taken off trial, most often because of progressive disease, adverse events, or death. As far as high-dose dexamethasone is concerned, only a minority of patients remain on trial, whereas the majority of the patients have discontinued or have been switched to pomalidomide. Response criteria were defined by an independent review committee. The objective response with high-dose dexamethasone is 4%, whereas for pomalidomide and low-dose dexamethasone is 16%. However, we have to keep in mind that many patients were accrued in the trial in the last 2 months, and we expect that the response rate will improve with time because it takes a few months to achieve the best response with pomalidomide and dexamethasone. The median time to response was short, about 2 months with both high-dose dexamethasone and pomalidomide. And this is the main curve because the main endpoint was differences in progression-free survival. As you can see, there is a statistically significant improvement in the progression-free survival of the patients from 2 months in high-dose dexamethasone to 4 months in pomalidomide and low-dose dexamethasone. Importantly, this difference in PFS was translated in a significant survival advantage. The median survival in patients randomized to high-dose dexamethasone is 34 weeks, and it has not been reached for patients treated with pomalidomide and low-dose dexamethasone, and it is expected to be around 11 or 12 months. To conclude, pomalidomide and low-dose dexamethasone has been shown in the context of a prospective randomized trial that is superior to the standard of care for patients with relapsed and refractory myeloma. Most of these patients were clearly refractory to both lenalidomide and bortezomib, and we believe that this may become a new standard of care for these hard-to-treat patients. Thank you.